Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Alan Lindemann. He's an obstetrics-gynecology physician. Today's Kevin MD article is titled Personalized Hypertension Care in Pregnancy Beyond Evidence-Based Thresholds. Alan, welcome back to the show.
Thank you, Kevin. Nice to be back.
So Alan's been on several times. Go to kevinmd.com/podcast. Go to the search icon in the upper right-hand corner. Search up Alan's name to hear his story and prior episodes. But today we're going to talk about a case, and let's jump right into it. So Alan, tell us how this story and article came together.
Well, I was reading the contemporary OBGYN, and there was an editorial by Dr. Swung, and she's talking about, oh, how nice it is now to have new evidence-based guidelines for blood pressure management that is chronic blood pressure management in pregnancy. So she was happy to have the new 140/90. And she was very happy that the 160/110 was gone. The problem is that I think ACOG never really ever told us we should wait until somebody gets to be 160/110 before we treat them. They have said that if we have somebody near labor or near term, if we have a blood pressure of 160/110, that they need to be delivered within half an hour. And that makes sense. And the only problem with that recommendation is it's not sensitive. In other words, there are many women who would get into trouble way before 160/110. So, well, I thought, okay, fine. I'm happy that we've decided to have a new threshold of 140/90. But still, what does that mean? You know, if you have a patient, if you want to wait until your patient is 140/90, or they come in 140/90 for their first visit, and that is what you require to treat them, then what do you do with somebody that's 138/88? Because in theory, they wouldn't be treated with that protocol, but on the other hand, they would have a lot in common with a 140/90. So I'm thinking, why do you need a protocol for this? Why do you need somebody else to tell you what to do? Can't you figure out what your blood pressure, how to manage this patient? So my wife was helping me with this, and I wanted to just kind of end it with that, but she said, no, you should put these other patients in there. So, okay, here we go. This is from many years ago. It was 1981, my first practice, young, naive doctor. But this lady came in with a blood pressure very close to 140/90. And I'm thinking, okay, what are we going to do with this? How much trouble are we going to have? Should we treat her? And in those days, we didn't know for sure whether treating her would help the baby, would hurt the baby, would help the mother, would hurt the mother. But I thought, this blood pressure is too high. I was worried about the outcome. So in those days, we used Aldamet. Of course, we don't use that anymore, but my patient didn't die. In any event, we kept her pressure right around in the 120s over high 70s, low 80s. She went on to term, and she delivered a 9-pound, 3-ounce baby vaginally with good Apgars. So, a high blood pressure doesn't need to end in disaster. You don't need to have eclampsia or preeclampsia. As a matter of fact, her blood pressure stayed quite stable throughout her pregnancy. So, the treatment didn't hurt her. It didn't hurt the baby. As a matter of fact, we have evidence that it probably did them some good. So, that, as far as I'm concerned, that's just using my head. We have another example, which is the extreme opposite. And that's a lady who came in. I was called in on this one. She had seen a family practice doctor, and her pressure was a little bit elevated, like 130/90, but she was 17 years old. And when I looked through the chart, I could see that her pressure starting out was 90/50. She was actually one of the most challenging and the sickest people I've seen in my entire pregnancy career, and it's been about 6,000 babies now with no maternal mortality and no seizures either, no eclampsia. So it's possible. I know it's possible. So anyway, I talked to her. I said, we're not going to get this baby out vaginally. Your cervix is not favorable. We're not going to do this with an epidural because it's just going to take too long. And I'm worried about what, your blood pressure becoming unstable. So
Yeah.
we said, we're going to do this general. We did, and everything turned out fine. Baby was fine. Good APGARs. Mom did fine. I did, though, give her some blood pressure treatment in the hospital. We kept her for an extra day, and I saw her many times as an outpatient. So, but she did fine. She eventually returned her blood pressure to 90/50. And so happy ending. But
So,
these are the extremes of blood pressure management.
so before going on, just give us a little bit of context for those of us who aren't obstetricians. How common is it for women to come in pregnant and their blood pressures elevated? How common is that scenario?
I would say it's quite common. One of the things we do right with obstetrics today, we have what we call the preeclampsia model. And that means that we check blood pressure, we check urine, we check reflexes, and of course, we check babies' heart rates and talk to moms and listen to moms. But many moms will have some blood pressure elevation, and I think probably as many as 10% will have a little bit of preeclampsia, something that if we just pay attention to it, in other words, stop working. If you have an extra job outside of the home, stay home, don't go to bed, but stay calm, because I think that our anxiety sometimes does raise our blood pressure. So I think you can, if you find these people early enough in pregnancy and treat them early enough and well enough, I think you can really manage preeclampsia without having it go to eclampsia. Like I said, I've never seen eclampsia in the 6,000 patients I've
Sure.
delivered.
And you mentioned that the American College of Obstetrician Gynecologists, they have new guidelines such that blood pressures above 140/90 should be addressed. Clarify and maybe expand on those new guidelines.
Well, this actually didn't come from the American College. It came from a study that
Okay.
Dr. Spong quoted. And actually, what they did, they treated these people with blood pressure medications, and they found that the outcomes were better in the treatment group than in the control group. But it's something I knew already. And I think that probably anybody with a little bit of common sense could also figure out. So I'm thinking, why do we need a study to
Mm.
tell us these things that should be obvious to us?
So there's always that tension, right, between guidelines and the art of medicine and the individualized patient. And it's not just in episodes of preeclampsia, but pretty much every area of medicine, right? That tension between standardization and that art of medicine. So talk more about that tension.
Well, thank you for that opportunity. As an old doctor now, of course, they can't fire me because I'm retired. So that's good. And it doesn't matter whether they take boarding away or not. But I do think that there is tension. We're not supposed to think very much anymore. If we look at the way we're trained in medical school, and you know how that is, it's more memorizing than it is learning. For example, they'll tell us on Tuesday that A plus B equals C, and then they'll ask us on Wednesday, what does A plus B equal? So that's not really learning, that's memorizing. I also know that we are really in love with evidence-based medicine. And to me, evidence-based medicine is a lot of times you take some iffy number, multiply it by something, and get a whole batch of other iffy numbers and have it make some kind of meaning. But I think that really, the art of medicine is like looking through a batch of transparencies down and then finding that experience that you've had that most nearly matches the present situation. That's experience, that's judgment, that's discernment, and I think some intelligence. So yeah, of course, in the beginning, when you're in your first year, you don't have a very thick pile to look through, so you don't have a lot of experience, but still, you can have that. I know we're not supposed to like the experience of one. I know that's anecdotal. It's not good, supposedly good medicine. But I think in the long run, when the rubber meets the road, that's the way we practice on a daily basis. That's how we make it through the day. That's how we take care of our patients.
So, in your eyes, in your opinion, what is the ideal role of evidence based medicine?
Well, it should give us at least some guidelines. And yes, I understand this study now says that we should treat 140/90. Great. I'm all in favor of that. But the problem I have with it is that 140/90 will only fit a certain group of patients. And there will be patients who fall outside of that group who need to be treated. Like, for example, the young lady with the 90/50. When she got to be 130/90, she was sick.
Do you feel the pendulum today has swung too far on the side of evidence based medicine to the detriment of those individual patients?
I think so. I think we really, if we look at the way things are happening now, I just read an article yesterday about now we have sepsis committees. Well, for goodness sakes, I've never had a patient die from sepsis, but you have to look at your patient. You have to know your patient. You have to go see them every day. You have to listen to them, and you have to take action, the right action at the right time. And to me, I sit back and wonder, why do we need, what's happening to us that we need to have our judgment replaced by a crew of so-called experts with somebody in charge? What happened to the personal responsibility? Like, when patients came to see me, I felt personally responsible for their outcomes. And if they were sick, if they got sick after surgery or sick after delivery, I was there. I didn't wait for the neurologist to come in or the surgeon or anybody. I was the first one there. And if I needed to call in a batch of doctors, I would do that. But we really need a doctor to be responsible for a patient. And we're missing that. And yes, we have these so-called committees that are trying to take the place of that, but still, why are the patient's doctors not in there on the front lines taking care of sepsis?
If a physician pushes back against the evidence, pushes back against guidelines in today's world, what can happen to that physician?
Well, every time you turn around, you're threatened with some kind of discipline for something or other. So yeah, you're probably gonna at least get a visit from some friendly person telling you that you ought to behave yourself. Unfortunately, today, thinking is going out of style. And in some cases, I think it's even considered bad practice. So, as somebody who's always been a little bit outside the box, I've had my share of lectures about how I ought to behave. But in the long run, like I said, if you look at my patients, there's no deaths associated with the patients I've delivered, and I haven't even had any serious illness. In other words, I have had no moms with a liver rupture, a liver capsule rupture. No 25-year-old ladies, or even for that matter, 45-year-old ladies permanent in the nursing home because of strokes, and no permanent kidney disease. So everybody's recovered. And I think a lot of that has to do with the fact that I liked my patients and I felt responsible for every single one of them. And that's what we need today.
What do you say to those proponents of evidence based medicine who say that these guidelines protect patients from practitioners who practice individually to the extent where their individual decisions actually harm patients, right? Because that's one of the arguments in favor of evidence-based medicines. We want to protect patients from physicians who may practice so far outside the standard of care they may actually harm patients.
Well, yes, I know that's the excuse that we give for our evidence-based medicine stuff. But in the long run, good results do count for something. And they are, in a way, a defense. If you go to even, in a court of law, if you get sued, you have to have a bad outcome. That's one of the four things you need. So a good outcome is a good defense, although certainly I think one of the things that the evidence-based medicine is trying to do is make up for doctors who don't feel responsible for the outcome of their patients.
Hmm.
There's a story, and this comes from NPR. It's a 33-year-old nurse, ICU nurse, who died from a stroke at the time of her delivery. And there were numerous times when people were talking about her blood pressure being too high. As a matter of fact, the nurses got so tired of it that they took the monitor off. They said, we know it's high anyway, so why do we monitor it?
Sure.
Well, she had a bad headache, so they were waiting for the neurologist to come in. Well, the neurologist needed to have some medication that couldn't get there for another 12 hours. And in the meantime, the patient stroked out and died.
Mm.
So nobody was in charge of her care. So I can understand that you've got evidence-based medicine and you've got groups of people looking at that and saying, oh, gee, if we just would have had a team take care of this, it would have been better. The problem with the team is that if everybody's responsible, then nobody's responsible. And we're getting back to responsibility again.
Alan, tell us some of your take-home messages that you want to leave with the KevinMD audience.
Well, I would say to patients, and again, we've got an audience that's bigger than patients, but if you're a patient, find a doctor who will listen to you. And if you're a doctor, listen to your patients. Take everything they say very seriously, no matter whether you think it's foolishness or not. Take it seriously, listen to them, because like an old friend of mine said, if you listen to them, they'll tell you.
Alan, thanks again for coming on the show and sharing your story, perspective, and insight.
Thank you very much, Kevin. Always nice to be back.